Hello and welcome to this session of the Center for Podiatric Education. And in this section, I'd like to speak to the subject of prophylactic antibiotics in podiatric surgery. We know that surgical site sepsis is not rare. There are approximately 1 million reported surgical infections per year. This results in an average hospital stay of about 7 days. Surgical infections increase procedure cost on average about 20% and is responsible for about $1.5 billion per year in additional healthcare costs. Now, from a patient perspective, this is often associated with increased pain, in addition to the increased cost the patient incurs because they're responsible for 20–30% of this, and frequently and unfortunately post-operative infections are not uncommonly associated with a poor surgical outcome. And not uncommonly we see litigation associated with post-operative infection. And oftentimes with litigation, the issue becomes whether or not the patient was in fact higher risk for the possibility of an infection, or failure to have recognized the post-operative infection in a timely manner, or a failure to utilize appropriate diagnostic studies, or the failure to appropriately treat the infection. An orthopedic friend of mine likes to say that there are two things that surgeons don't like. One thing is seeing patients after surgery, and the other is post-operative infections. And that's probably true, because we know that the outcome for a significant post-operative infection is going to be less than optimal in many circumstances. You know, we tend not to think about this in today's world, but this quote from Johns Hopkins Medical Journal back in 1982 gives one pause for thought that the greatest impact of antibiotics is the fact that it has allowed us to advance surgery. You know, you think about the history of bone and joint surgery, and before antibiotics, a post-operative infection was a serious, limb-threatening, if not life-threatening event. And now we don't restrict ourselves to closed or minimal incision surgical procedures as was done years ago. And what has exploded is elective surgery, and most of us don't give much thought to the possibility of infection, because we A, have prophylactic antibiotics, and B, we feel comfortable that if an infection does develop, that we're likely able to control it with appropriate therapy and appropriate antibiotic use. So we utilize implants now and hardware, and talk to patients about elective surgery, and we feel comfortable that infection really is not likely to be a major risk, and it's antibiotics that really have advanced that ability. In looking at post-operative infections as is applicable in our profession, we have soft tissue infections and bone infection. And in looking at a patient that has a post-operative infection or surgical site sepsis, we try to assess whether or not we have just cellulitis, or whether the cellulitis is representative of a deeper process. So it's important to evaluate the patient, treat them initially for cellulitis, recognize that they may have an occult process deeper, and monitor patients for signs or symptoms suggestive of a deeper process. So we have cellulitis, which is typically strep or staph. We have infected hematomas, which of course require in many or most instances, incision and drainage and irrigation. We have the presence of an abscess following surgery. We have infected osteotomies or infected arthrodesis sites. We can have infections of fracture with or without operative intervention. One of the more complex issues would be that of the infected non-union. We can have infected joint implants. We have the patients that have inflammatory changes and are thought to have rejected hardware, if you will, or an allergic reaction to hardware, which sometimes in hindsight is actually reflective of a deep infection. We have the patients that have those chronic draining wounds and they don't otherwise look clinically infected. A good example of that might be sinus tract fistula that we may see following arthroscopic surgery, and of course pin tract infections. Now, what are the things that we can do to reduce the risk of infection other than just the use of prophylactic antibiotics? Well, obviously one is patient selection. If it's a diabetic patient, we want to see that their diabetes has been under good control, that their A1C is at a reasonable level. We want to avoid surgeries in patients who are malnourished, who are anemic, patients that have poor vascular supply, poor skin condition, that type of thing. So patient selection is very important, as we know that the sicker patients that confront us that require interventions, elective or non-elective, probably have, as a general rule, a higher risk of infection. We want to make sure that proper preoperative skin decontamination, scrubbing, and cleaning is performed. Antibiotic prophylaxis, when indicated, is certainly a part of infection incidence reduction. Obviously, we want to perform surgery in a clean surgical environment. We want to use a good surgical technique, and we want to avoid urgent elective surgery in patients that have correctable comorbid conditions, so that we can look at the patient that perhaps wants a bunion corrected or a hammer toe corrected or needs a stabilization procedure for posterior tibial tendon dysfunction or a total ankle replacement. And we want to look at these patients medically and fine-tune them when these are elective procedures and not turn this into an urgent issue where the patient ends up with an infection when we could have taken our time, perhaps improve their vascular flow, improve their nutritional status, perhaps improve their diabetes, that type of thing. Generally, looking at the formula for a determination of the incidence of infection, we know that infection will increase the more the concentration and virulence of organisms. We know that all wounds are contaminated at the time they're closed. Bacteria enter the operative site, so we would expect that the larger the wound, the longer the wound is open, the more likely we have a greater concentration of bacteria. And of course, the virulence make a difference. The more virulent the bacteria, the less bacteria required to cause an infection. Whether or not the organism is resistant to antibiotics. Typically, we will give beta-lactam antibiotics for prophylaxis to cover the major pathogens such as Staphylococcus or Streptococcus. On the other hand, if we have a multi-drug resistant organism or an MRSA, we may have given appropriate antibiotics, but the organism is resistant to those antibiotics. We know that tissue injury plays a role in infection, and the more traumatic the surgery, the more damaged tissue we leave behind, the more receptor sites we leave behind to which bacteria can adhere and lead to infection. And we also know that foreign materials play a role in infection. And we know that the more foreign materials that we implant, the higher the risk is of infection. And I always marvel at the pressure put on us by various orthopedic suppliers to utilize a variety of implants and other agents. And I always say to myself, anytime I utilize an implant, I'm raising the potential not only for a reaction to the implanted materials, but also for infection. So I wonder whether or not we really need some of these materials. And a real good example in my mind are the many things that are implanted in patients when doing retrocalcaneal surgery. I mean, this is an area that's at times difficult to heal to begin with, and I see my colleagues throwing in anchors and various orthobiologics around the Achilles tendon, and I just wonder how much this contributes to the wound breakdowns that we see. The healthier the patient, the greater the local and host immunity, the lower the rate of infection, and antibiotic prophylaxis certainly plays a role in lowering the rate of infection. Now, the role of implantable materials, and this was an example of one of my patients that had a infection associated with an undissolved vicral suture, and this appeared literally years after the surgery. We know that even a single silk suture will reduce the resistance to infection 10,000 times. And looking at the number of bacteria required to create an abscess, you could see a substantial difference when no silk suture is utilized versus a silk suture. So there's no question that the use of foreign materials raises the risk of infection, and that's probably the reason that one should always consider the use of prophylactic antibiotics when leaving behind various implants such as screws and plates and anchors and so forth. Now, what about the use of prophylactic antibiotics? Well, they should be used in appropriate patients. They need to be administered within 1 hour of surgery, and they should be discontinued certainly within 24 hours. This was a patient of mine who had undergone a simple arthroplasty of a second toe and developed a wicked cellulitis rather rapidly. Now, the use of antibiotics in appropriate patients is critical. I was the expert witness in a malpractice case some years ago for the defense, and it was a rather tragic case. Patient was undergoing surgery for a ganglionic cyst, a middle-aged female with no real medical history, and she was allergic to penicillin. The surgeon ordered clindamycin for prophylaxis. He gave the block for the ganglionic cyst excision. It was in a local surgery center, and he made the incision and then asked the nurse anesthetist if they had remembered to give the antibiotic. And the nurse anesthetist said, "Oh, geez, I forgot. Let me give it now." And gave the clindamycin. And the patient reacted to the clindamycin and died. So a lawsuit entailed, obviously, against the anesthetist who had pushed the clindamycin, and of course you cannot give clindamycin by IV push, which was done, but they also sued the surgeon. And in this particular state where the surgery had been done, the law was such that if the anesthesiologist is not in the room, the surgeon would be responsible for the actions of the nurse anesthetist. Well, we were able to have the surgeon dismissed from the suit, fortunately, and there was a substantial settlement against the anesthesiology department and the nurse anesthetist. So I was talking to a friend of mine, an orthopedist that I frequently have breakfast with and share stories, and I was telling him about the case. And he said to me, why was the patient getting any antibiotic at all? After all, this was a simple excision of a ganglionic cyst in a healthy patient, and there really was no indication for any prophylactic antibiotic. Now, this may be an unusual case, but I'm certain if we were to know the truth, there is more than one patient in this country that reacts to, in some manner, negatively to the use of antibiotics administered with good intention, but unindicated. So we do want to restrict our use of antibiotics to those circumstances where prophylactic antibiotics are indeed required and are indeed necessary, because we can have adverse sequelae to an antibiotic. Again, it's important to remember that the antibiotics should be administered within 1 hour of the surgical procedure. Now, inappropriate utilization, giving antibiotics when they're not indicated, does not prevent operative site sepsis. It contributes to antibiotic resistance, as I've already indicated. You can have an increased risk of adverse reactions, and it increases healthcare costs for no reason. So it is not true that it's a good medicine, proper preventive medicine, to give prophylactic antibiotics to everyone. As far as choice of prophylactic antibiotics go, we know it's a major tenet of prophylaxis that you want to protect the patient against the major pathogens. And you're not going to cover rare organisms, and generally that means Staphylococcus and Streptococcus and gram-positive cocci. So here's an example of a patient of mine who developed a Pseudomonas osteomyelitis following a scholastic implant arthroplasty, and certainly the patient would not have been covered, and in fact was not covered in this circumstance, but there was no reason to provide coverage for Pseudomonas in this patient. So we know the most common organisms are staph, enterococci, streptococci, coag-negative staph, and this is important to prophylax against, and this should represent your major consideration, unless there are unusual circumstances. Now, where do these germs come from? This was a patient of mine who unfortunately was sent to me following a total ankle and triple arthrodesis with a staphylococcal osteomyelitis. So we do see these cases. Obviously, where do these organisms come from? They come from the patient's own skin generally, which is why we want to look at the area where the surgery is going to be done and see that that skin is in good health, why we want to have proper skin prep. They sometimes come from the nares, and this is why some patients are screened for staph and MRSA. They can come from the GI tract and GU tract, from bronchial infections and respiratory sinusoidal infections. We can have, obviously, the introduction of bacteria through contaminated instruments or implants or personnel. Of the organisms that are transient, the majority come from instruments, personnel, or various surfaces that the wound comes in contact with, and really only about 30% are airborne. Now, sometimes we have circumstances that would seem to dictate an increased risk of infection. This was an interesting malpractice case. The patient is undergoing a minimal incision Austin-Aiken surgery with a Dremel drill, and this is being done right in the podiatry chair. Now, the patient came to this doctor with a friend who was considering having bunion surgery done, asked if she could sit there and watch the procedure, and the surgeon in this case was very obliging, and so the girl was taking pictures of the surgery with the surgeon wearing sterile gloves and using a Dremel drill with what was argued to be a sterile burr. At the end of this, unfortunately, the patient developed a significant infection and went on to litigate against the podiatric physician. Sometimes we see things that are real attention getters. In this case, a doctor was performing a surgical procedure in the office. The patient alleged that the instrument fell on the floor, and the surgeon picked up the instrument and continued to use it even though it had already hit the floor. This resulted in an infection and litigation. Certain procedures we know tend to be associated more with problems. This was calcaneal fracture, ORIF, with a standard extensile incision, which at the time was a very popular way to approach these things. And we know that wound breakdowns and infections were not rare with these fractures. Anyway, the standard selection is going to be against staph and strep, and that's going to be Ancef or cefazolin most commonly, or cefuroxime, again administered within 1 hour of the surgery. If the patient has a true beta-lactam allergy, then generally vancomycin or clindamycin are considered the appropriate alternative choices. If the patient has a known MRSA risk, then probably vancomycin is your antibiotic of choice. Again, this should be administered, if it's cefazolin, within 1 hour of making the incision, so that we have a large amount of the antibiotic in the wound at the time the wound is open. Vancomycin should be given within 2 hours of making the incision. You want to make sure the antibiotic has been administered prior to inflating the tourniquet. If the patient is greater than 80 kilograms, then you want to give 2 grams rather than 1 gram of cefazolin. Now, timing is important, and this was the famous experiment of Burke, who administered antibiotics at various times after inoculating experimental animals with staphylococci. So staphylococci were placed or inoculated in the wound, and then antibiotics were given at various times. So he looked at the development of the growth of the bacteria and the infectious process, and the later the antibiotic was given after the surgery, the more extensive was the infection that occurred following inoculation, so that it is best to administer the antibiotic at the time that the surgery is ongoing. We want to remember that all wounds are contaminated when they are closed. When we do a surgical procedure on bone, we are exteriorizing the bone. We are exteriorizing the internal surface of the body, so that all wounds are contaminated, and we have the attachment of bacteria to various receptor sites within the wound. It can be bone collagen, it can be components of hematoma, fibronectin, damaged vessels, but the bacteria will adhere to receptor sites, and the race for the surface begins. That is to say, when we close the wound, we have the normal human mechanisms of defense against bacteria, against infection, cellular and humoral mechanisms of defense, opsonization, and so forth. And then we have the bacteria that are trying to adhere, grow, and colonize in that wound. Hopefully, the patient's health is such that their immune system can rid them of the bacterial contamination. But when we have less vascularized tissue, patients in poorer health, patients that are anemic, patients that are immunocompromised, and so forth, then the bacteria have an advantage, and they are able to successfully adhere to the surface of the bone, to grow on the surface of the bone, and as they do so, to create a complex polyglycocalyx or slime layer, so that the bacteria create the characteristic of osteomyelitis, which is the sequestra, and we end up with an area of bone that is now devascularized, so that we don't have blood supply to the area, and we cannot get humoral or cellular mechanisms of defense to that area. The sequestra is encased in the polyglycocalyx or slime layer, and the bacteria are therefore protected by this biofilm from attack by cellular and humoral mechanisms of defense. From that sequestra, the bacteria then invade and infect the surrounding tissues. Now, if we give antibiotics, they can get to the areas that are vascularized and healthy, and we can suppress the infection, but we cannot ultimately cure the infection because the antibiotics and antibodies and so forth cannot get to the bacteria. And ultimately, we have the classic marker for osteomyelitis, and that is the sequestra. And this is the reason that once we have established osteomyelitis, particularly if it is chronic, that we must debride the wound. Now, if we have antibiotics that are in the wound at the time that the bacteria are introduced in the wound, this will slow down the growth of the bacteria and tilt the advantage to the patient's own immune system and mechanisms of defense. Thus, the more bacteria that are introduced, the more foreign bodies that are introduced, the less healthy the patient, the more virulent the bacteria, the more likely we are to get a postoperative infection. And conversely, with prophylactic antibiotics and with a healthier patient, we're less likely to progress to the point where the bacteria can isolate a portion of the bone, surround it with a biofilm, multiply, and then invade and infect surrounding tissues. When we have biomaterials present, the problem is that the bacteria will adhere to the biomaterial. They will grow on the biomaterial. They will produce their biofilm underneath that biomaterial. They will then grow from that biofilm mediated growth center to the surrounding tissues and invade and infect those surrounding tissues. This is the reason that loosening of an implant and lucency about an implant can be a marker for the presence of a biomaterial moderated infection. So here again, we can administer antibiotics. They can get to the non-biofilm contained bacteria, so long as those tissues are vascularized and otherwise healthy. So our immune system, antibiotics can get to those bacteria, but they will continue to reside on the implant under the biofilm. And this is the reason why in many cases, if not most cases, when a biomaterial is present, we have to remove that biomaterial in order to effect cure of the infection. Now, there are some exceptions. If one is giving antibiotics and the patient is improving clinically, if they're improving laboratory-wise, if we don't see loosening of the hardware, if healing is progressing, then we can assume that the implant is not interfering with the treatment of the infection and allow the biomaterial to remain in place. However, if it is clear that the infection is recalcitrant to care, that we're getting loosening of the implant, that our treatment does not appear to be as effective as we would desire, then it's probably best that the biomaterial be removed. Sometimes for long surgeries, it is important to administer additional doses of antibiotics. If you're using cefazolin, then that dosage should be repeated somewhere between every 2 and 5 hours, cefuroxime every 3 to 4 hours. If it's clindamycin, every 3 to 4 hours, and vancomycin, hopefully your surgery is not going this long, but if it is, after 6 hours to 12 hours. So additional doses are required based on the half-lives, or if there's been, again, something that doesn't happen often in podiatry, significant enough blood loss where the antibiotic may even be lost within the blood loss. This was a patient of mine from many years ago. It was a juvenile bunion that I treated by a Logroscino procedure. Those of you that are old enough may remember the Logroscino procedure, where we did a osteotomy of the first metatarsal at the proximal level to reduce the intermetatarsal angle, and then did the equivalent of a Reverden procedure or Peabody procedure up at the head to reduce the proximal articular set angle. And this was a patient who developed an infection around their K-wire. We did go ahead and remove the K-wire, did a quick debridement, instituted rapid antibiotic therapy, and the patient went on to heal with a very excellent clinical result. In any event, looking at special populations, there are those that argue that we do have certain populations that are at increased risk for infection, and that prophylactic antibiotics should be utilized in those patients. This would include patients with diabetes, particularly with some degree of vascular disease, and neuropathy, since we know that neuropathy is a major factor increasing the risk for infection. The obese patient, patients who are of older age, smokers are known to have a higher risk for postoperative infection, as are ex-smokers. Patients who undergo urgent or emergent surgical procedures, patients who have obviously contaminated wounds, and immunosuppressive therapy patients, as we know that in today's world we are seeing increasing use of immunosuppressive therapy, not only for cancer patients, but for inflammatory arthritic disorders, for inflammatory skin disorders, inflammatory bowel disease, and so forth. So you're going to make that decision individually, but in general, there is a trend toward recommending prophylactic antibiotics for patients who are at statistically greater risk for infection. You may want to consider prophylactic antibiotics in patients who undergo extended or prolonged surgeries, if there's going to be retained fixation in implant materials or implant arthroplasties. In general, it's considered appropriate for fixation, implant material retention, other than standard sutures, obviously, and joint implants, to go ahead and use prophylactic antibiotics. This was a case from litigation. It was an Austin procedure that became infected. The podiatric physician in this case chose to not remove hardware early on. This was from the days of K-wire fixation of Austins, where the K-wire was protruding. The patient became infected. The doctor was very reluctant to remove the hardware. Eventually, unfortunately, the patient had a septic necrosis of the metatarsal head. This led to a first-ray amputation and a lawsuit, and I remember speaking to the doctor and asking why, when you had drainage and obviously signs of a potential infection, did you not remove the Kirschner wire earlier? And his answer to me was, well, I was afraid of getting a non-union. And you know, there's an old saying that the only thing worse than a non-union is an infected non-union. And so here again, more appropriate early intervention might have been helpful. There are a number of local factors that also can be considered with prophylactic antibiotics. Patients with higher ASA class risk are considered at greater risk for infection, generally because their higher ASA class means that they have more comorbid conditions. Again, foreign body retention, the use of excessive electrocautery, It's been suggested by some that the use of epinephrine may be associated with increased risk of infection. Retained wound drains may be associated with increased risk of infection. Removing the hair with a razor prior to surgery and operating on areas that have been previously irradiated. We also know that certain types of wounds are more likely to be infected, meaning dirty wounds, contaminated wounds, and clean contaminated wounds. But we know that even with a clean contaminated wound, or a contaminated wound, or a dirty wound in general, the use of prophylactic antibiotics is going to be associated with decreased risk of postoperative infection versus surgery under those same circumstances without a prophylactic antibiotic. It's kind of interesting to look at compliance with prophylactic antibiotics. This particular study looked at whether or not surgeons were following recommended guidelines for prophylactic antibiotic in terms of choice of antibiotic, dosage, timing, and duration. And the indications were generally followed. That is to say, 83% of the time the antibiotics were being prescribed in appropriate patients, but administration was only appropriate in just over 50%, and overall compliance with guidelines just over 1/3 of patients. So even with all we know today, it can be difficult to achieve total compliance in the use of prophylactic antibiotics. So in summary, I don't think there's any argument that prophylactic antibiotics are effective in reducing the incidence of surgical site sepsis. It certainly does not prevent all infections, but it reduces the incidence. You want to do surgery on proper patients, and good patient selection will reduce the incidence of infection. You want to use the correct drug and the correct dosage. You want to utilize correct timing within 1 hour of surgery, within 2 hours with vancomycin. You want high serum levels at the time that you're doing that surgery, so as the bacteria enter that wound, they're either killed or impaired, such that your immune system wins the race for the surface. So that, again, using the IV route, using appropriate high dosage and timing are critical. You want to redose the antibiotic if there's a particularly long surgery or if there's significant blood loss. And probably antibiotics are not indicated once the wound is closed. If you feel that antibiotics are indicated after surgery, then terminate them within 24 hours. Another old saying that I've always heard from infectious disease is that surgeons use the most antibiotics in any hospital and know the least about them. And this day and age of antibiotic mentoring and calls for decreased unnecessary and inappropriate use of antibiotics, I think we need to think long and hard about this, because most of us tend to use antibiotics more as a security blanket, and unfortunately there are potential adverse reactions to them. One question that does come up quite a bit is what about the patient that's had a total joint replacement, and do I give prophylactic antibiotics to that patient even if I'm not doing a long surgery or a surgery with retained foreign material? And the answer is, if the patient is an immunocompromised patient, if they have insulin-dependent diabetes, if it's less than 2 years following their joint replacement, if they have a history of prior implant-related sepsis, if the patient is malnourished or the patient is hemophilic, then yes, it is appropriate to give a prophylactic antibiotic, even though you may be doing a soft tissue procedure, one with which typically prophylactic antibiotics are not used. Lastly, we've seen tremendous changes over the years regarding the indications for prophylaxis for endocarditis, and generally the indications are mitral valve prolapse, acquired valvular disease, patients with congenital cardiac malformations, patients with hypertrophic cardiomyopathy, patients with complex cyanotic congenital heart disorders, and patients with surgical pulmonary shunts or conduits. I thank you for your attention, and hopefully this will be helpful to you in your practices.